Dr. Dow is here with a talk on understanding and managing sleep disorders in Smith-Lemli-Opitz syndrome. Dr. Mark Dow is a neurologist who graduated from Tufts in 2024 and is currently enrolled in a sleep medicine fellowship at Beth Israel Deaconess Medical Center. Ladies and gentlemen, Dr. Mark Dow.
Hello. So my name is Mark. So I'm gonna be doing a talk about like how we would approach the sleep disorders in patients with SLO, as well as I'm gonna be borrowing a little bit from the literature on patients with autism spectrum disorder and patients with ADHD, because we see there's a lot of overlap. And as you know, like the research is, we don't have a lot of research on the specific syndromes, but we know there's probably a little bit more research on the people with like autism. So that's why we're gonna be basing some of our recommendations and some of the clinical things we would do or we would go for. So my goals for this is kind of like to go over what the major sleep problems we see in this population, as well as what are some unique challenges, because as we know, like it's difficult to get some of the studies done in the pediatric population, because it takes like a lot of workforce. Most of the studies we do are not very comfortable, but then it can add like a more like a bigger challenge if there is underlying behavioral difficulties or like difficulty like following commands. So that's why we try to be very selective, so we don't add more stress and burden to the. Is it good? Okay. To the kid and the family. And then we were gonna go over some of the potential treatment, and then how we would approach it. And again, I don't think there's any, even melatonin is not like technically FDA approved for the use in pediatric sleep medicine. So a lot of it is gonna be based on our experience and like taking from the literature on other disorders. So like the first part of my talk, I'm just gonna go over, there's a couple papers that were really interesting where they sent surveys to parents of about 18 to 20 kids with SLO, and then it was more of a subjective overview of like what behaviors would be there, what sleep problems would be there. So again, the studies I'm gonna be going over, there's no objective data, there's no like polysomnogram, there's no actigraphy, it's more questionnaires. But I think it's good enough and give us an idea about what families deal with on a nightly basis. And one thing that was interesting, I think that we can go back to it at the end, is as we know, there's like a relationship between the severity of the deficiency of the enzyme and the level of like DH7, as well as the severity of the physical defects. However, there's like small studies that show that there's also a correlation between the level of cholesterol as well as the sleep difficulties, but there's not as much correlation between that and the behavioral. So what that means, like you can have, like a kid can have mild deficiency or cholesterol level changes, but still have a lot of behavioral abnormalities, which can also affect sleep. So I mean, like the sleep problems can be present in all of the population as well. So this is a table like from a paper by Freeman in 2016, and then there were like, although there was like, as you see, there's no strength seen in the study, but there was like some overall like correlation between the sleep disturbances as well as various plasma sterols. And then correlating with the severity of the disease, and they've noticed that there's if you have the worse, like the high, like the lower the cholesterol and the higher the 7-DHT is, there's a correlation between that and the decreased total sleep time as well as increased sleep onset latency. And that's going to be important for us because those are going to be two of the most common problems we see in the clinic, and then we have to find ways to help them overcome it. And then this is like as I said, there isn't a lot of literature on the topic, and one of the papers I think that was maybe the most complete was the one from like the recent one from Zerowski in 2011, and then in this one where they were able to they sent the questionnaires to parents of 18 kids with SLO, and the questionnaires were looking at different problems. We had like daytime problems, we had nighttime problems, as well as like during the night there were like sleep behaviors issues as well as breathing disorders. So it's kind of like it would be that was not like the kids who, like the parents who responded yes for snoring, for example, which was a big part, like about like 50% of the people who said like the kids like sleep with their mouth open. It doesn't mean they have sleep apnea, but those are two symptoms that we would see more commonly in kids with sleep disorder breathing. The same for like when they're like very fidgety or very restless at night. That's not by itself, based on this questionnaire, it's not going to be a diagnosis. I cannot come and say they're going to have more restless legs, for example, which is like a disorder when you would be very fidgety or have the urge to move your legs in the evening, and it can it's usually relieved by walking, but then it can interfere with the sleep onset latency and allowing the kids or older individuals to be able to fall asleep and stay asleep. And for the rest of this part of the talk, I was gonna just divide it into two categories. The first one would be the sleep disordered breathing, and as you can see, there's like based on the responses on this one study, there was about 50% who did report snoring, about 67%, 2/3 who did report mouth breathing. So there's possibly like an increased risk of sleep apnea or sleep disordered breathing, and then we're gonna see like some of the risk factors we see in kids with SLO, and then the other part of the disorder, like, or the problems we're gonna be talking about is like how quickly can kids go to sleep, and are they able to fall asleep, or if they wake up, are they able to go back to sleep? Which both of them were issues like frequently reported in the study. And then one more thing, I think Dr. Tierney, she did talk about like the prevalence of anxiety as well, and then we see that some of the behaviors, like bed sharing, or like needing the one of the parents to be in the room for them to fall asleep, or needing something on, the light on, both of like these like behaviors can sometimes point towards possibly some sleep-related anxiety, as well as what we call like sleep associations. So for the sleep associations, this is something we see more commonly in the pediatric sleep clinic as opposed to the adult sleep clinic. The reason being is everybody does, normally we all wake up during the night, like at the end of every sleep cycle, you go through all the stages, and then you have like a short wake up, and then you kind of like toss and turn, fluff up your pillow, and go back to sleep. However, in kids, either like kids with SLO, kids with autism, or even kids neurotypical, like there's like sleep association can be present in all of those children, and what that means is like when they wake up spontaneously during the night, they would be requiring whatever the last thing they saw when they went to sleep, they require it again for them to fall back asleep. So, and that's why we, like I say, if they require their parents to be at the bedside to put them to sleep, when they wake up naturally, spontaneously during the night, they don't see their parents, they're going to start crying, and they're going to wait until the parents come back for them to be able to fall back asleep. So that's what we call association. This is something we can also work on switching the association, like instead of having it linked to the parent, for example, or like mom, dad, or I don't know, maybe the TV or something, then we can have them have like an association object, for example. So let's say associate your sleep with a blanket you sleep with, and then when you wake up, you see the blanket, and you're able to go back to sleep, for example. And then those are the symptoms during the daytime. And the reason I'm bringing this one up is, there's a lot of ADHD-like symptoms, a lot of inactivity, there's a lot of hyperactivity, there's a lot of possibly throwing tantrums or behavioral the changes. But those behaviors can also be can also correlate with a bad night's sleep. I've had a lot of patients tell me they can do very well, but if one night they don't sleep well, they're they are a different person. And the problem is, one bad night of sleep can lead to daytime sleep, and then it can disrupt their entire sleep cycle. So it's when we try to address the sleep issues, we're also trying to minimize the behavioral problems during the daytime, and probably also avoid over-medicating for behaviors during the daytime if they are related to sleep issues, because this way we would be medicating or treating the core of the problem. So for the sleep disordered breathing, I wanted to point at. So this is not an exhaustive list of the physical defects or the anatomical changes we see in individuals with SLO, which is a spectrum. But I mainly wanted to point at some of the changes that, if present, can by themselves increase the risk for sleep disordered breathing and sleep apnea, because there isn't enough, already kids when they're growing up, their tonsils, and we're going to look at the picture, so for example, we have the tonsils, we have the lingual tonsils, we have the palatine tonsils, and we have the adenoids. All of these tissues, they usually grow faster than the space that's around, because they start growing at around age 2, but then their face or their heads are still smaller. So that's why they can be they can obstruct or lead to more obstruction, for example. But imagine if we had even less space to begin with. For example, the microagnatia that we have here. So let's say if the jaw is smaller, so the space that the tongue has to move inside the mouth is smaller. With the presence of the high arched palate or the cleft, it leaves also less room for the tongue to move around, so that increases the risk for sleep disordered breathing. And then also we see some of the kids have low tone, which can also contribute to increased risk of increasing the risk of the tongue falling back, or even increasing the risk of hypoventilation as well in some of those kids. And then how do we diagnose sleep apnea? Sleep apnea usually is there's a lot of symptoms that could be suggestive. We cannot make a diagnosis of sleep apnea by just looking or talking to someone, because there's a lot of people who snore that don't have sleep apnea, and there's a lot of people who have sleep apnea and not big snorers. So, but usually what we would base our pre-test probability on is, do they have any of the symptoms that may suggest sleep apnea, such as snoring, gasping, choking, even witnessed apneas. If you watch a kid sleep, they're gonna have a lot of pauses. Some of those pauses are normal, some may not be. But the things when they become very frequent or prolonged pauses, this is not normal. This is very suggestive of sleep apnea or sleep disordered breathing. And if we want to test for it, unfortunately, in the pediatric sleep medicine world, we don't have yet home sleep test. But let's say for all like older individuals above age 18, we can do like home sleep test, which is I think it would be great if we're able to get it done for even pediatric patients in certain cases, because that takes away from the stress of having the kid being in a completely different environment with a lot of wires like on their head. And we'll see like a picture of what like they're not all as happy as this kid here. So like they would have like all the wires and like wraps like around their head. Like all of the times like at Boston Children's, like usually like when in an adult sleep lab we have one tech for 2 or 3 patients. In a pediatric sleep lab you have to have trained, like specially trained sleep technicians, and they are usually on a one-on-one like ratio. So like and this is only like they only have the EEG leads. So they're still like they would have like one on their finger they would have like an oximetry on their finger, like which is like a sticker on their finger to measure their oxygen level while they're sleeping. We'll have like a belt, as you can see here. There's 2 belts, one belt around the chest and one belt around the belly, and this is to measure the breathing while they're sleeping. So like you want to see, like we would be testing using this like the nasal cannula here. There's no oxygen going through. We are just measuring the air that's going in and out. So what sleep apnea would be is like there would be no air going through the nose or the mouth, but then you would still see effort in the belt, like in the chest and belly belt. So they're trying to breathe, but there's an obstruction upstream that's preventing the air to actually be able to go through. And in very rare cases, we may do an overnight oximetry. It might be helpful sometimes. Let's say if we want to see like what their oxygen level is there like any concern for like hypoventilation, but it's really rarely used in the clinic on its own as a diagnostic test for sleep apnea. So this is what the oximeter looks like. It's like a sticker on the finger, and they have to keep it on so it's measuring the oxygen while they're sleeping. So once we diagnose sleep apnea or sleep disorder breathing, what can we do? Fortunately, like in kids, a lot of the times sleep apnea can be cured via surgical approach. Like usually what we can do, like there's like taking the tonsils out, taking the adenoids out if they are big. Sometimes if we have kids who have like milder cases of sleep apnea, we can do like nasal steroids, for example. Like they can help like improve the airways in the nose, as well as shrinking a little bit the tissue, especially in the adenoids, which are like at the back of the nose. And then we can do like PAP therapy, which is the CPAP. It's a positive airway pressure. So as you can see here, there's like this is the mask, and this is like it wraps around the nose, and then there's the tube, and this is connected to a machine which we call the CPAP machine. It's gonna be pushing air at a constant pressure through the tube into the nose, and the goal of it is to keep the airway open and prevent it from the tongue collapsing or from like the airway to narrow more. So this can be used. It doesn't have to be used long term, like because like a lot of the times, like let's say if they're not candidate for surgery or they don't want to do surgery, we can do like CPAP until like you're fixing other things, like until like if they are like overweight or obese, or like if there's like they're losing weight, so that could be a bridge until they lose the weight they need to get like take care of the sleep apnea. Or it can be used until like they grow a little bit, like their face grows, so there's more space. So it doesn't have to be as an adult like always a lifelong therapy. And then there's always also one thing I like to point is like although like there's a lot of like medication out there, but we always like to not prescribe medication as a first line, because you're always especially in kids, we can always retrain them to sleep better. And I think it's very important to it's very important to reinforce this at the beginning. We can always add on medication to help them sleep better, but we wanna make sure that the medication does not replace the behavioral changes. So the behavioral changes need to be there, and then we'll add the medication to help. And usually kids with autism or kids with ADHD, kids with SLO, they might be like more in need of medication, but it doesn't mean like they wouldn't benefit from the behavioral changes as well. And then for the follow-up therapy, we don't always have to do the follow-up therapy unless, let's say, usually what we do is like, we'll like we always if we have a moderate severe sleep apnea, we send them for surgery. We usually do like once they heal, there's not as much edema, we bring them back to the lab for a repeat sleep study just to make sure that the sleep apnea has been taken care of. The second part of the talk, it's going to be about the insomnia, which I think it's the bigger, like one of the biggest concerns, and most of the kids I've seen in the clinic with autism or ADHD, SLO, they're like most of the time, like sleep maintenance has been the biggest issue, and like sleep onset as well, but sleep maintenance I've noticed as like this is what's most concerning for the family as well, because it disrupts everybody's sleep as well. So the reason I'm putting this one here, as I said, like we're during this talk, I'm going to be borrowing a little bit from the evidence and our experience in kids with autism as well as ADHD, and then also like I just put in like a few names here about some of the neurotransmitters. So like usually like in the brain, you have like different levels of control of sleep. You have like the cortical level, like which is around the brain area. And then you have like medications that would act on this parts of the brain to promote sleep. And this is one of the areas where we can use some of the benzodiazepines like the lorazepam or Ativan that it's been talked about. There's like other levels, like you have like levels around the thalamus, which is like somewhere in between, where like in between your brain and your midbrain, which is the base of the brain. And then you have like other neurotransmitters that are involved in some of like sleep initiation and like sleep on, sleep off kind of neurons. And then some of those neurotransmitters are the orexin. And this is like a very exciting, it's very exciting times. I'm hoping that maybe in the next few years we're gonna have easier access to some of the medications that would target those neurotransmitters, because those neurotransmitters can work on initiating sleep. And it's been, at least in the adult population, it's been shown to increase total sleep time without having as much of the sedating effect, or it doesn't change as much the sleep architecture as other medication do. And then we also have like possibly in some of those kids, they might have like abnormal melatonin levels. It can be either the levels are abnormal, or it could be the timing of the melatonin can also be like abnormal. And then there's also possibly some like dysregulation within in the serotonin syndrome, which like is involved in the sleep connections, but can also explain some of the other like anxiety or other mood problems we can see. And how would we approach them? Usually it's what we try to do is like we try to see what the problem is, and then what's an easy usually by and unfortunately especially in sleep medicine, the wait time is really long, and we try to be very mindful, because for example like parents might have been like struggling with their kid for like 6-7 months before they were able to even come and see us. So like by that time, like we want to try to give them all of the tools, like even if we don't do all at once. It's like, hey, we do this at first. Like I know that a lot of the times we get, when we talk about the behavioral changes, like it doesn't seem too appealing. So sometimes what we do is like we add, like we can do add some medication. We'll give you the tool to try, but use it maybe a week or two after you start implementing the behavioral changes. So this way they know that they're not going into the unknown. Let's say if I do all of this and then I'm going to have to wait another 3-4 months to come and see you, then this is another 3-4 months of like no sleep. So what we usually ask about, we ask about the history. Like we see like how much time are they staying in bed. We see like what time are they going to bed, what time are they waking up, what do they do before going to bed, like what's their exposure to light, to screens. And then one thing that we've noticed is usually kids with ADHD and autism spectrum disorder, their sleep needs might be less than the neurotypical kid of the same age. So say if a neurotypical kid who's 8 years old, on average they need, let's say, 10 hours of sleep. Like we don't know for sure how much, but it seems like the same age kid with autism and ADHD might need less. So if you're spending the same amount of time in bed, this is going to lead to like sleep fragmentation, because they're not able to fill the entire hours they're spending in bed with sleep. So it's important to see how much time are they spending in bed. Like, do they take any naps? How do they go to sleep? Do they go to sleep by themselves, or do they need someone to go to sleep? How do they sleep on the weekends versus the weekdays? That can sometimes also tell us if there's like, how much the anxiety is playing a role. Or how do they do, like when they're on vacation or during the summer, for example, how do they do with the change of seasons? Because that sometimes can also tell us if there's like a circadian component to it. Like is their biological clock not in sync with their, like, the timing they're going to bed? So all of these are important questions we would ask, because they can also guide our treatment for the kid. We usually some of the things we would find very helpful is like sleep diaries. So sleep diaries are very important. We'll show you what a sleep diary would look like, but also we can sometimes supplement it with an actigraphy. Actigraphy is a watch you'd be wearing. It's kind of like a smartwatch, but a medical grade one. And then it's usually based on the movement. It can estimate the times you're sleeping and the times you're awake, or the time you're active. So it's helpful to see like what their sleep-wake cycles are. And usually we would do that alongside the sleep log, just because, to make sure, like, because sometimes like the actigraphy can under call things. So it's always good to have two things to compare. We would ask parents to get us like videos of their kids, let's say, especially if they're reporting some abnormal behavior while they're sleeping, if they wake up crying, screaming, yelling, acting their dreams. Like, we want to see, like, it can help us, like, know, does it look like a seizure? Does it look like a parasomnia, like night terrors? Like, is it like a nightmare? What does it look like? So it's always useful, especially when there's like some abnormal behaviors that the parents are worried about. Just get it on video. That would be very helpful as well. And then if needed, we do get this like a polysomnogram. We're not as eager to jump towards the polysomnogram in the pediatric population as opposed to the adults, because adults can go there. They don't have to need someone to be with them, but especially in kids, we would like to only keep it if we have a high pretest probability for sleep apnea. So we would send them for a polysomnogram. And then one thing that's actually interesting is the iron profile. We would a lot of those kids can be very restless at night. They're not able to always communicate what's going on. But let's say, like, I've seen like a couple kids where they just be like scratching their leg like in the evening, every evening before they go to sleep, and they just appear to be uncomfortable. They just keep sitting up, scratching their leg, going back to sleep. And then they had like low iron. It doesn't need to be super low. Usually we go by a ferritin of like less than 50, but those can be like the presenting symptoms of restless legs for like in the pediatric population, or even restless sleep if they just toss and turn. I've had like parents tell me like their kids would wake up in all different positions. They would wake up sleeping like upside down, or like they're just like it's kind of like a storm went through the room through the night. So it's important to address those issues, because like some kids might need IV iron, but a lot of the times they would do better with oral iron to begin with. And this is what the sleep diary would look like. This is a 2-week sleep diary. So it starts midnight here, and then goes like 1 through 11 a.m. and then this is the afternoon. So what we don't, it doesn't need to be very like an exhaustive like what's going on. All we need is like what time are they going to bed, what time are they falling asleep, and what time are they waking up and getting out of bed. So that's kind of like all we need to get like most of the information we need out of the sleep log. And how would we approach it? I think we talked a lot about the non-pharmacological approaches, which like I have another QR code from Autism Speaks, because this is something we use in a lot of patients, even if they don't have autism. Like if they like because autism is like a big spectrum, and the tools we have on this website can be helpful for a lot of kids, because there's a lot of visual cues. There's a lot of visual like things you can do, like a routine you can do. And then sometimes it's also for kids who are in ABA therapy, their therapist can take advantage of those tools and include them in the therapy, like teach them how to go back to sleep. For example, like last week, one of the kids I've seen in the clinic with autism, and like his answer was like he goes to sleep well, but he wakes up, and his answer is like, but he stays like up for like 2-3 hours without being able to go to sleep. And I was gonna ask him why, like what goes on through your mind, like why you cannot go to sleep. He's like, I don't know how to. So a lot of those kids is like, it's like what seems very easy, like they might not be able to do it. They might be, and they might need the help with this, and this is where the visual cues can be helpful. And they can be also included with their therapy at school, kind of like, hey, like things you can do to soothe yourself, put yourself back to sleep, teach them those skills again. And then also those behaviors can improve the overall sleep quality, sleep consolidation. I'll talk a little bit about it in the next slide, but I wanted to also bring up here, I know that we talked at the beginning, there's a potential link between cholesterol, metabolism, sleep disturbances, but so far there hasn't been really like strong studies looking at like cholesterol supplementation, or I know there was like a study on simvastatin use, and it did make a small difference in like the behavioral like changes, but like none of the studies I think are like, this is an area where there's a need for more studies, because it might be an important target for the future. And the multidisciplinary approach is always better. Like, you know, it's always better like when we are able to work with psychiatrists, neurologists, sleep specialists, all within the same center, or at least all connected, because it makes it easier. For example, like it's way more difficult for me to get in touch with a psychiatrist like at a completely different institution, because you have to call, wait for them to call you back, or like, you know, like not being like missing their call. Like it's really difficult, as opposed to having all within the same center. Then like you can just, you know, send a message, be like, and that's also better for the family and the kids as well. The non-pharmacological, so this is the QR code for the Autism Speaks, that has some of the tools, like some of the pictures they can use to teach them how to go back to sleep and how to sleep on their own. And I think it's important, like, you know, like just like talking about like sleep hygiene, regular bedtime, like screens, light, because like a lot of kids can be lights can be very stimulating. Like establishing like a bedtime routine, like establishing, because like, you know, like all kids, they like patterns. Like when they see like there's like a pattern, every time I do this comes next. This, like, you don't need communication, you don't need verbal communication to understand that. So like a lot of the times you can like teach them patterns, and then that can help with establishing a more healthy routine. In high, like I know that it's SLO is like a spectrum. So there's like, you know, there's like milder cases, moderate, and more severe cases. And usually sometimes we can use some tools that like, for example, the bedtime pass, that would not apply to all the kids. Even in the clinic, we use it mostly, like the kids need to be old enough to understand, and they need to be like high functioning as well, because like what it takes like the bedtime pass, it's a very good idea for the correct kid, because what it does, it gives them the ability is like, hey, you are in charge of your sleep. I'm gonna give you this pass. You can use it for whatever you want, but you get one pass per week or one pass every 2 days or whatever. And the day you don't use your pass, you get something good. You get like you get a gift, or you get, I don't know, like a point, and then if you get 10 points, you get something. So what it says, like, when the kid has the pass and they're sleeping, they know that if they wake up and they're not able to fall back asleep, they don't need to be afraid or anxious because they can still use it. But there's also the positive reinforcement. It's like, you know what, I have it. Let me try do it on my own, because like if I don't use it, I'm gonna get something else in return as well. So they can use it, for example, to like you can use it for, you would give it to, like if you want, you would give it to the parent, and then for like a visit for the parent, or you can come into the bed with us for the night, or you can get something to drink, something to eat, or you can exchange it for something, and then that's it. You're done for the night, and then you have to go back and sleep. For the medications, I have a couple more minutes. So for the medications, as I said, there's no approved drug, technically in pediatrics. I put them together in like different categories. Melatonin is the first one. Like the first category is like that will act on the melatonin. I have the melatonin itself, and I have the ramelteon. We've had really good luck with ramelteon in the clinic. The ramelteon is a melatonin agonist, so it works on the receptor of the melatonin 1 and 2 receptors. It lasts for practically about like our experience has been, it lasts for about 6 hours, 4 to 6 hours, and it does work well for work well with not without a lot of side effects. So it's like a safe medication. We usually try. The doses are 4 to 8 milligrams. And then the other medication, like for the melatonin, the dosing, it depends on what you're using it for. When we use the melatonin for sleep onset to help them, so we use 1, 2, 3 milligrams. If we're using it for sleep maintenance, we want to keep them asleep, we would use an extended release formulation. But if we're using it for kids who are there's like some circadian, their biological clock or their brain is not aligned with when they're going to bed, we'll use it at a way lower dose an hour or two before bedtime. So the use is different. So I always recommend don't go too high on the melatonin. Always reach out, because I feel like having it available, and it may seem safer than it is. You don't want to be taking too much of it. The alpha adrenergic drugs, this is where the clonidine and the guanfacine are helpful. The clonidine is a very helpful medication. We use it a lot. It's usually one of our first go-to medication in the clinic. It can help with behavioral. It can help with anxiety. It can help with ADHD, and it can also help with middle of the night awakening as well, because of it has a short duration of action, about up to 4 hours, up to 4 hours, and it usually doesn't lead to daytime grogginess. So it's a useful medication. You want to just keep a watch out for the blood pressure. The gabapentin is another medication. It has an indirect GABAergic effect. Although it has GABA in it, it doesn't work on the GABA receptor. But it's helpful because we have a liquid formulation for it. So we have a lot of kids who cannot take pills, so we can use this one. And then it's good that it lasts usually 6 hours or so. It can last throughout the night, 6 to 8 hours, and then it can be helpful in restless legs or restless sleep as well. The orexin antagonists are newer drugs that are very promising. They help keep they can increase total sleep time, and they would work on a different. They work uniquely on the orexin. So usually you can combine them with other medication. So let's say usually you would want to when you're combining two medications, you want to maximize the effect. You don't want to get two medications that work on the same receptor or same or the same place. And then there's the iron supplementation. For the antipsychotics, we don't use them a lot in the clinic. We just want to be careful from some of the drugs that might increase 7-DHC, like trazodone, aripiprazole, because they can have a similar form to piperazine, which is the DHCR7 inhibitor. So this is a table with the half-life, some of the common side effects. Most of these drugs are usually well tolerated, and then this is the drugs for the orexin antagonist. The reason I put so we have 3 drugs on the market, with the difference between the newest one is the QUVIVIQ. The difference between them is the half-life and the duration of action. And then the price are usually expensive, so that's why we sometimes have to go through multiple drugs before we can get them approved. And so in conclusion, I think there's like a lot of things we can do for the kids. It's important to see them in the clinic, like get the history, like get like a good sense of like what their routine is, because this is the first place where we want to start making changes. And then there are a lot of medications, but again, all of the medications are all trials. There's no like studies on each of the medications, so every kid is going to be different, and we shouldn't get discouraged if the first one doesn't work. We'll go to the next one. We can always combine medication. It's going to be a long journey, but it will be a journey we'll be taking together with the family. And that's it. Thank you.